Hi, everyone. Welcome to today's National Neonatal POCUS Collaborative webinar. Sorry for the delay. We're having some technical issues. We're still working on pulling up Dr. Glau's slides, but we'll go ahead and get started with some housekeeping items. So just so you all know, the chat is disabled for the audience, but you may see some chat messages come through from the moderators who will send out general announcements via the chat. Please use the Q&A feature to post questions, and we will answer those after Dr. Glau's talk during the Q&A panel session. This webinar is being recorded and will be uploaded to the collaborative website, neopocuscollab.com. So I will now introduce our guest speaker today, who is Dr. Christie Glau. Dr. Glau is an assistant professor of anesthesiology and critical care medicine at the University of Pennsylvania and an attending physician in the PICU at the Children's Hospital of Philadelphia. Her PhD was on the usefulness of lung ultrasound in bronchopulmonary dysplasia. Her research centers on point-of-care ultrasound use within the pediatric critical care medicine, including ultrasound-based assessment of lung and diaphragm mechanics, ultrasound use in pediatric septic shock resuscitation, and ultrasound education and programmatic development. She is a past chair of the Society of Critical Care Medicine, Pediatric and Neonatal Ultrasound Committee, and currently serves as the director of the CHOP Pediatric Critical Care Medicine Ultrasound Fellowship Program. She has many publications on neonatal lung and diaphragm ultrasound, mainly about the use of lung ultrasound for monitoring very preterm infants during their NICU stay. We are so honored to have you here today, Dr. Glau. If you could maybe get started just verbally telling us your presentation, and then once we're able to get your slides, then we'll share that and we'll catch up to you if that works for you.
Okay. All right. Thank you so much for inviting me here today. I'm sorry for the technical difficulties that we're having. So I wanted to talk a little bit about functional diaphragm assessment and how you can use point of care ultrasound in your practice to assess diaphragm contractility. So we'll talk a little bit about the developmental differences in neonatal and infant diaphragms. We'll talk about different measurements you can do with ultrasound to try to figure out whether your patient's diaphragm contractility is improving or worsening. And then we'll talk about potential clinical applications for it that you can potentially put into practice where you are to help assess your patients. So the diaphragm, just to remind everyone about the anatomy of the diaphragm, it's a dome-shaped structure. It's arranged around a central tendon. The diaphragm dome, sort of the part of the dome that wraps around, is located right next to the chest wall, which makes it really convenient for ultrasound imaging because it's a very superficial structure. The part of the diaphragm muscle that is lies up against the chest wall is called the zone of apposition. Contractility in that zone of apposition is responsible for the bulk of the work that your diaphragm does. And so measuring the contractility in this region is really the best place to assess your diaphragm's overall contractility rather than imaging the tendon portion, which obviously doesn't do any of the contraction. As the diaphragm contracts, the dome of the diaphragm moves downward during inhalation, and then there's passive recoil of the diaphragm upward during exhalation. Really importantly to using diaphragm ultrasound in neonates and infants is understanding what the developmental differences in the diaphragms of neonates and infants are. So it's important to realize that neonates and infants rely more heavily on the diaphragm to generate their inspiratory force. Since they have immature chest wall musculature, they aren't really able to recruit those accessory muscles when they have times of respiratory distress like older children or adults would be. The positioning of the diaphragm puts it, unfortunately, at a mechanical disadvantage in neonates and infants. The dome of the diaphragm is more flattened in young children, which makes the angle of insertion not as optimal for generating inspiratory force. It really puts the diaphragm in a mechanical disadvantage. There's also less of the zone of apposition of the diaphragm that's actually in close relationship with the chest wall, which makes coupling of the diaphragm with the chest wall to generate the inspiratory force a little bit less ideal. As you all well know, better than me in the PICU, the chest wall of infants is, because of the delay in ossification, is very flexible. Therefore, during the passive recoil of the chest with the increased compliance, the lung volumes often drop below FRC even within tidal volume breathing, and especially during times of respiratory distress. So the inspiratory force that it takes to re-expand the lungs back to FRC and then for a full tidal volume breath are quite a bit higher in infants because of that chest wall compliance. And then finally, the infant and neonate muscle fibers themselves are different in makeup and also in structure. So infants have a higher proportion of fast twitch muscle fibers and less of the endurance, slow twitch fibers that help with muscle endurance in older kids and adults. It's thought that the fast twitch muscle fibers have lower oxygen demand, which might decrease the work of breathing for infants, even though they have a higher proportion of fast twitch muscle fibers. But infants also have a lower cross-sectional area of muscle fibers, so they generate less force per unit area of their diaphragm. So there's a lot of things that make the infant diaphragm and neonatal diaphragm less equipped to do its very, very important job. So as far as different metrics of diaphragm structure and function, diaphragm thickness is the, oh, you got my slides up, great. So if you can move to the next slide. And then the next one. So the zone of apposition, which if you could actually back up to the anatomy slide real quick so I can show people the picture of the zone of, there we go. So the area of the diaphragm that is close to the chest wall is called the zone of apposition. That's where the majority of the force is generated, and really where you want to stick your probe when you're trying to measure diaphragm thickness. If you could go ahead and advance back to that picture of the diaphragm thickness measurement. Great. So to measure diaphragm thickness, you're going to want to use a linear probe, a high frequency probe. You'll want to put it in the 9th or 10th rib interspace. And then you'll see the diaphragm as a band of muscle located in between two echobright lines. Those two echobright lines, one is the diaphragmatic pleura and the one below is the peritoneal membrane. And the diaphragm muscle lies right in between there. I've been doing diaphragm measurements for so long that the machines that I used before had really pitiful resolution. And so when I started doing this, I measured from the outside of the diaphragmatic pleura to the outside of the peritoneal membrane just to help with really small diaphragm measurements. But now the resolution is better. And so the convention is to measure in between those two connective tissue layers and measure the diaphragm itself. So you can make these measurements in B mode. You'll want to make sure and orient your probe perpendicularly to the chest wall to get the best resolution possible. Next slide. Diaphragm thickness varies by age. Up at the top of this chart, you'll see preterm infants, and you can see there's a general increase in diaphragm thickness with gestational age, which is smaller than in term infants. And then in children, there's not a real significant difference in diaphragm thickness between different age groups. The measurements are a little bit higher in teens and adults, but there's really not a statistically significant difference in those measurements. Next slide. Great. There was some thought that a positive pressure ventilation and applying PEEP could hold the diaphragm in a partially contracted state, which might make the thickness of the diaphragm different during positive pressure ventilation than in spontaneous breathing patients. This is one of the studies that I did on healthy children in the operating room getting elective surgeries. And I found that there was no difference in diaphragm thickness between pre and post intubation, which kind of has important implications for tracking diaphragm thickness over time, especially if you're tracking someone's diaphragm thickness as they move from being intubated to on non-invasive positive pressure, and then finally off of respiratory support. Next slide. There are a couple of different metrics that you can use to track diaphragm contractility. We'll move to the next slide here. The first one is diaphragm excursion. So for diaphragm excursion, you're going to use the linear probe again. You're going to place the probe in the subcostal position in the midclavicular line. You're going to aim a little bit medially and cephalad to image the dome of the diaphragm. And what you're trying to capture is the distance that the dome of the diaphragm is displaced downwards during inspiration. So when the infant takes a breath in, the dome of the diaphragm is going to be displaced downwards towards your probe. Next slide. And when you image that in M mode, it's going to be reflected as a movement of a positive deflection of the diaphragm towards your ultrasound probe. And then you measure the distance between the baseline position of the diaphragm during exhalation up to the position at maximum inspiration. And that measurement will give you the distance that the diaphragm has moved during inspiration. Next slide. So diaphragm excursion, interestingly, for premature infants, there's actually a decrease in diaphragm excursion that happens with as the gestational ages increase. Because of the compliance of the chest wall can actually move inward during inhalation, which can pose a mechanical disadvantage, and the diaphragm actually has to exert extra work in order to generate the same tidal volume with the chest wall having moved inward. So as you move from the youngest infant in this, or neonate in this chart, from 26 weeks up to 37 weeks, you can see that there's a gradual decrease in the excursion. And then once you get up to the infant and older children age, the diaphragm excursion increases sort of proportionally to height in older kids. Next slide. Diaphragm excursion, because mechanical ventilators assist the efforts of respiration, you have an offset of the work needed to be done by the diaphragm to generate the same tidal volume. And so in this same study in the OR, where I looked at healthy kids that were getting elective surgeries, between pre and post intubation, the excursion of their diaphragms went down because a lot of the work of breathing was done by the mechanical ventilator rather than the patient themselves. So you can see a clear difference between pre and post intubation diaphragm excursion. For patients on mechanical ventilators, it's really important to realize that the diaphragm excursion can be altered by tidal volume. So the larger the tidal volume breath, the further the diaphragm is going to be displaced during inhalation. And if you have partially assisted ventilation or something like BiPAP or pressure support ventilation, that extra pressure support that the patient's getting is going to cause their diaphragm to move further. And so diaphragm excursion is really optimally assessed during non-assisted ventilation if you're using that to determine what the patient's native diaphragm contractility is unassisted by any mechanical ventilators. Next slide. So diaphragm thickening fraction is another metric that you can use to assess diaphragm contractility. It's really akin to cardiac shortening fraction, where during contraction, the muscle fibers slide past one another and the muscle bed thickens up. And you can compare the thickness during inhalation to the thickness during exhalation, and use that to calculate a diaphragm thickening fraction. Next slide. So you're going to measure this in the same location that you measured the diaphragm thickness at the 9th or 10th rib interspace at the zone of apposition. Next slide. This is what it's going to look like in B mode. So the diaphragm is going to be that band of tissue in between the two echo bright lines. On the left and the right-hand side of the clip, you'll see ribs with some shadowing below there. And then just inferior to the ribs, you'll see the diaphragm. And you'll see as the patient exhales, the diaphragm thickens up. And as they exhale, the diaphragm thins back out as the contraction subsides. Next slide. So diaphragm thickening fraction has been shown to increase proportionally with spontaneous respiratory effort. So in patients under neuromuscular blockade, it's barely present. During controlled ventilation, it's a little bit higher. Then when you get to partially assisted ventilation and then healthy subjects at rest, the thickening fraction increases as the patient's respiratory effort increases. The diaphragm is the most resistant muscle in the body to neuromuscular blockade, so there still is a tiny bit of thickening fraction present even under neuromuscular blockade, but it's usually in the like 0 to 3% range. Next slide. Diaphragm thickening fraction has also been shown to increase proportionally with maximum inspiratory pressure, so it's a good marker of a patient's maximal inspiratory efforts. Next slide. So what this is going to look like, instead of measuring the thickness in B mode, like you did earlier when we were just looking at the thickness, you'll measure this in M mode. And so with M mode, you'll get a dynamic picture of what the diaphragm thickness does over time. So you put the M mode cursor down through a single sort of sliver of the diaphragm tissue. It's important to do that a little bit inferior to where the lungs end up during inhalation, because during inhalation, the lungs, as they insufflate, can move through your field of view. And if they move through the plane of your M mode cursor during the time that you're measuring this, you won't be able to get a full picture of what the diaphragm thickens to during inhalation. So if you find that the lung is blocking your field of view, just move a little bit more inferiorly on the diaphragm. And so at point A there, you'll notice that the diaphragm's thicker, and that's the diaphragm thickness during inhalation. And then at time B, that's the thickness during exhalation. Next slide. So mathematically, you'll calculate this as the inspiratory diaphragm thickness minus the expiratory diaphragm thickness divided by the expiratory diaphragm thickness, and you'll get a thickening fraction. Next slide. This has been well characterized in preterm infants. Up in that top table, you'll see that there's not a big difference in diaphragm thickening fraction by age. So in the research that I've reviewed and what I've seen is as the chest wall compliance decreases and the dome of the diaphragm isn't as flattened as the gestational ages increase, the efficiency of your diaphragm goes up. And so with the same effort and the same thickening fraction, children with larger thoracic cavities or neonates with larger thoracic cavities are able to generate adequate tidal volumes without having to contract their diaphragm as much. So there's really not a statistically significant difference in thickening fraction for preterm neonates. It's a little bit higher, in fact, in children, older infants, and then school-age children. As the chest wall ossifies and you get decreased compliance and you have more effective coupling of the diaphragm with the chest wall, you're able to generate adequate tidal volumes with even less thickening of the diaphragm muscle because the contraction is just much, much more efficient than it is in neonates. Next slide. Similar to diaphragm excursion, diaphragm thickening fraction goes down during mechanical ventilation. So that left-handed image of the M mode shows the diaphragm thickening fraction pre-intubation and then post-intubation on the right side panel. Next slide. All right, so diaphragm dysfunction has been a hot topic. So next slide. So this is sort of taking what we've learned with diaphragm excursion and diaphragm thickening fraction and putting it into practice. So the next couple slides are slides of children who are have had thoracic surgeries or cardiac surgeries. This is an infant after TEF repair, and diaphragm excursion was used here to detect diaphragm paresis unilaterally. You'll see a stark difference in the image on the left-hand side of the screen is the right diaphragm, and the image on the right-hand side of the screen is the left diaphragm. And there's a big difference in the excursion of the left side versus the right side, which is due to a phrenic nerve injury during their TEF repair. Next slide. Additionally, this is a more severe case of a complete paresis where you have paradoxical diaphragm motion. So instead of the diaphragm being displaced downwards during inhalation, you have a paradoxical upward movement of the diaphragm that happens during inhalation. There are good data of neonatologists and cardiac intensivists using point of care diaphragm ultrasound to detect diaphragm paresis after cardiac surgery. So there's good precedent for that being used for that purpose. Next slide. Critical illness diaphragm dysfunction. This is sort of an amalgamation of all the things our patients are exposed to in the NICU and in the PICU. You have a patient who's critically ill. They are on some level of mechanical ventilation, be it invasive or non-invasive. You've offloaded their diaphragm. It's kind of like putting your leg in a cast. If you don't use the muscles, you lose it. And with this, if you are partially supporting the respiratory efforts of your patients, you can cause muscle fiber atrophy and decrease cross-sectional area of the muscle fibers there on the right side on the muscle cross sections. In addition to that, you have some oxidative stress. You have sometimes sedation medications, which deepen your sedation and lower your respiratory effort, neuromuscular blockade, things like corticosteroids, some antibiotics. All of these things can coalesce to create diaphragm dysfunction. Next slide. This occurs really quickly. So in muscle biopsies of rats, there starts to be mitochondrial damage that happens within 6 hours of starting mechanical ventilation. Within 18 hours, you get generalized muscle atrophy that you can see on a biopsy of the diaphragm, and it's visible for us on point of care ultrasound within 24 hours of mechanical ventilation. Next slide. So the clinical impact of diaphragm dysfunction, this is an adult study looking at adults with diaphragm dysfunction. They had longer lengths of hospital stay, they had higher mortality. Next. They had longer mechanical ventilator times, and they had more failure to wean from mechanical ventilation and had a longer overall time spent trying to wean them from mechanical ventilation. Next slide. The rate of diaphragm atrophy in adults is similar to that in children and in preterm neonates. The most pronounced time of atrophy is within the first 24 hours of mechanical ventilation. It's progressive thereafter. It's not in as high of a magnitude as it is during that first 24 hours, but it does progress until patients are able to start doing some spontaneous breathing. Next. So that's in adults. This is a study I did in a sort of heterogeneous group of kids with acute respiratory failure. Their diaphragms atrophied a median of 3.4% per day. As you follow that spaghetti plot out to the right, you can start to see an upward inflection in some of the kids that were intubated for longer. And that's really when we started doing reconditioning with these kids. So lowered their mandatory rates and let them spontaneously breathe more. Kind of used pressure support to give them more of a workout. And some of those kids, we did CPAP pressure support sprints off of full mechanical ventilatory support. And they did start having some recovery of their diaphragm thickness. Next slide. This was a study in preterm infants less than 28 weeks. There were 30 of them. Their average diaphragm thickness on day one was 1.27 millimeters, and their average diaphragm thickening fraction was 35% on day one. You can see a pretty pronounced change from day 0 to day 1 in both of those parameters. It's most pronounced on day 1, day 0 to day 1, and then sort of slows down thereafter. Next. In the study of kids intubated for, older children intubated for acute respiratory failure, their diaphragm thickening fractions correlated really strongly with spontaneous breathing fractions. So we looked at the number of spontaneous breaths versus mandatory breaths those patients took over the preceding 24 hours that we measured their diaphragm thickness. And their thickening fraction was really, really highly correlated to the degree to which they were allowed to spontaneously breathe. So using lower ventilator set rates and optimizing your pressure support to support their minute ventilation and tidal volumes leads to less of a loss of their thickening fraction. Next slide. Neuromuscular blockade, unsurprisingly, we use that a lot more in the PICU than you do in the NICU, but children on neuromuscular blockade infusions both had a greater overall degree of diaphragm atrophy and loss of thickening fraction during mechanical ventilation. Next slide. And they also had a greater or a more rapid rate of thickness loss. So they, all comers in that study had a decrease in diaphragm thickness of 3.4% per day, and the kids under neuromuscular blockade had a decrease of about 5% per day of diaphragm thickness. Next slide. We also found in that study that children with a greater degree of diaphragm atrophy were more likely to have prolonged non-invasive ventilation after they were extubated. So children that required prolonged non-invasive ventilation for more than 48 hours had a median change in diaphragm thickness of 21%, whereas those who required no non-invasive or non-invasive for less than 48 hours had a median atrophy of only 7%. Next slide. So these are some other diaphragm ultrasound applications. A lot of them are in the neonatal world. I think it probably ultimately diaphragm ultrasound is likely more useful in your patient population, since their respiratory efforts are so dependent on diaphragm function. So I'm really excited to try to collaborate with our neonatologist here to try to research this in your patient population a little bit more. It's useful in the PICU, but I really think it is most useful in your patient population. Next slide. So in this slide is just to illustrate the offloading of work of the diaphragm. This is a titration of non-invasive support. So with pressure supports of 15, down to 5, down to 0, you can see that the diaphragm excursion generally increases as you decrease their pressure support and make them do more of the work of their own breathing. Their thickening fractions also increase as you stop doing as much work for them. Next slide. In some of the adult studies, they found that diaphragm thickness for some patients during their course of mechanical ventilation decreased. So some of them had atrophy. Some of them actually had increase in their diaphragm thickness, and some their diaphragm thickness stayed about the same while they were intubated. So they looked at this a little bit closer. Go ahead and click the next one. And for those patients that had diaphragm atrophy, their diaphragm contractile activity, so their thickening fractions were much lower, which was reflective of their diaphragms being over-supported. So their mechanical ventilators were titrated, their support was titrated so high that they weren't asking the diaphragm to do any work. For patients who had diaphragms who increased in thickness, those patients were being asked to do sort of super physiologic contractile activities. So you see that they have contractile force or thickening fractions that are much higher than what we see in normal healthy patients at rest. And those patients were really under supported on the ventilator. So they were being asked to do more work of breathing. With that came more oxidative injury to the diaphragm. They start laying down abnormal muscle fibers and disorganized muscle fibers, and they started laying down fatty deposition tissue in their diaphragms. And so even though their diaphragms were thicker, the force that their diaphragms were able to generate actually was lower because they weren't able to, the tissue organization wasn't as good. So this has led to sort of a new line of inquiry in diaphragm ultrasound, is thinking if you can use diaphragm ultrasound to titrate your mechanical ventilatory support to keep patients' diaphragm contractility within a normal physiologic range rather than over supporting or under supporting, you'll probably end up with healthier, better conditioned diaphragms over the duration of their mechanical ventilation. Next slide. So it's also, diaphragm ultrasound's also been looked at as a predictor of extubation failure. For pediatric patients, it seems like diaphragm thickening fraction is the most predictive of extubation success. So in this study, a diaphragm thickening fraction of greater than 21% had an area under the ROC curve of about 0.9 for predicting extubation failure for pediatric patients. And for pediatric patients, the diaphragm excursion didn't perform as well. Next slide. For infants, this one didn't calculate ROC curves, but they did find that there was a statistically significant difference in both diaphragm excursion and diaphragm thickening fraction for infants. And then next slide. And then in this study of preterm infants, these infants were all less than 28 weeks. They were mechanically ventilated with on SIMV with tidal volumes of about 4 to 6 per kilo. And the real difference that you see here is that the predictors of extubation failure, the diaphragm excursion performed much better than diaphragm thickening fraction, which I thought was really interesting. And it may have to do with the decreases in excursion fraction that we saw as gestational age increased, because younger infants of younger gestational ages really have to exert more force and have to have higher larger excursion of their diaphragm to support the tidal volumes that they need. So the excursion ended up being a more sensitive predictor of extubation success for them. So with an excursion of greater than 2.7 millimeters, that was 94% sensitive for predicting extubation success, with an area under the ROC curve of like close to 1. Next slide. There was another study looking at CPAP failure of preterm infants. So these were neonates less than 34 weeks with a mean of 31 weeks or so on a mean CPAP of 5.5. They did measurements of diaphragm excursion and thickening fraction both before CPAP was applied and right after CPAP was applied. And they saw significant differences in both diaphragm excursion and thickening fraction between children who or neonates that were successful in being supported with CPAP versus children that weren't successful in being supported in CPAP and had to be progressed to invasive ventilation. So looking at that, the area under the ROC curves, the solid line is for the measurements before CPAP was applied, and the dotted line is for after the measurements after CPAP was applied. And both diaphragm excursion before and after CPAP application, it was pretty predictive, with the area under the ROC curve of higher than 0.8 for CPAP success. Next slide. Diaphragm ultrasound and BPD. Children, neonates with BPD have thinner diaphragms than healthy same age group comparators, but higher diaphragm excursion and thickening fraction, which was hypothesized to be because of the increased work of breathing that they have to do to inflate lungs with a lot of parenchymal injury. And so the authors of this study were proposing to use diaphragm thickness as a marker of how well supported their respiratory efforts were. Next slide. So really the take-home points are that the diaphragm is very, very easy to image. I can teach other people to do it in less than 5 minutes. It's much easier than cardiac ultrasound. The diaphragm is really superficial and you can image it really well. You can measure contractility with excursion or thickening fraction, and there's a lot of potential clinical applications of this, including titration of both non-invasive and invasive mechanical ventilatory support, predicting extubation or CPAP success, monitoring diaphragm atrophy and critical illness diaphragm dysfunction, and then also detecting diaphragm paresis after thoracic procedures to look for phrenic nerve injury. And with that, I'll take any questions.
Dr. Glau, thank you so much. That was an incredible talk and so inspiring to think about all the potential applications. We'll now move on to our expert panel discussion. So please put any questions into the Q&A and I'll relay them to the panelists. So joining Dr. Glau today, we have Drs. Monty Sharma and Caleb Cave. Feel free to turn your cameras on, Dr. Sharma and Cave. So Dr. Monty Sharma is an attending neonatologist and a pediatric pulmonologist at Children's Nebraska in Omaha. He is the director for neonatal POCUS at Children's Nebraska and part of the CHNC BPD collaborative. Dr. Caleb Cave is a second-year neonatal perinatal medicine fellow at the University of Nebraska. His fellowship research focuses on investigating the utility of lung field and diaphragm ultrasonography in predicting positive steroid response and successful weaning from mechanical ventilation. So thank you all for being here. So the first question is for Dr. Glau from our audience. I noticed that your example of M mode for diaphragmatic excursion was done with a phased array probe instead of linear. I think you mentioned, Dr. Glau, that you use a linear probe for both excursion and thickness. So do you switch to the phased array probe for M mode?
That's a great question. So most of my research is in the PICU population, where in order to get the depth that you need to measure diaphragm excursion, you have to use a phased array probe because the linear probe won't give you enough depth. But for all of you in the neonatology world, a linear probe gives you more than enough depth to image both, so you don't need to switch back and forth um, between both probes. So for older kids, I will use the phased array probe only for diaphragm excursion. For diaphragm thickening fraction and diaphragm thickness, you can use a linear probe, and then for your smaller kids, linear probe all the way. The resolution is much better. It's just a depth problem for me with the bigger kids.
Got it. That makes a lot of sense. And then a question for all the panelists. Do you have invasive NAVA at your institution? And if so, have you noticed any differences in diaphragm excursion between conventional ventilation and invasive NAVA?
So I'll let Caleb and Monty field that. We don't have NAVA here, but I have read some literature, but they probably have better firsthand accounts than I would.
Honestly, we don't use a ton of invasive NAVA, but we have a good amount of data now for non-invasive NAVA because that's what we tend to extubate all of our kids to. And we do see differences in excursion. I'll let Caleb talk more just about what he's seeing day to day.
Yeah, so again, like Dr. Sharma said, don't really do a lot of invasive NAVA. That was a very interesting question. I did notice that when we were just kind of scrolling through the chat before we started the panel. But yeah, the research that we're specifically doing, we're looking at the role of diaphragmatic excursion and lung field ultrasonography to kind of predict a successful response to steroids, and specifically in kids that are getting steroids, such as a dark horse, to facilitate extubation if those kids stay extubated. And so we have seen for kids that are on any mode of non-invasive ventilation, once they're successfully extubated, typically those kids that have actually more diaphragmatic excursion, especially in kind of like that younger population, tend to do better. Our sample size isn't huge, so and this is obviously not published data, but that is something that we've been seeing, just kind of the preliminary results.
And anecdotally, what we see on NAVA is more excursion, and that might speak to the synchronicity of it, right? Like you're getting a breath that's timed to the milliseconds of when the catheter is detecting a breath electromyographically. So what we do end up seeing is you'll get more variability in our peaks on diaphragm excursion, and it somewhat almost matches what you're seeing on the ventilator screen on the servo U's, right? Like your EDI peak to min, if you've seen the delta on those, it's almost as if it matches up. It's not always perfect. I know that the company tries to sell it as the perfect mode of synchronicity, but there's of course variability. Of course it kicks out, but when it's working and the kid isn't freaking out just because you're doing your scan, we do end up seeing more excursion breath to breath. Wouldn't you agree, Caleb? I feel like we see more variability on NAVA than we do on intubated assist control, at least, which I think was another question someone asked, is that there's a lot more homogeneity in diaphragm excursion when we see it in assist control, either whether it's spontaneously triggered or ventilator delivered triggered breaths. So I'd imagine you'd see the same thing invasively as well, that on the excursion metric, you would see differences based on what your delta is because it's so dependent on the insufflatory flow provided by the ventilator.
Dr. Glau, is there anything else you'd add based on the literature, or that sums up what we know.
No, I think that's perfect. I think the other thing to remember about the diaphragm excursion is that it's dependent on your tidal volumes. And so if you are optimizing their tidal volume by synchronizing up better with their breath, then you could certainly expect larger diaphragm excursion with NAVA than non-NAVA.
Excellent. The next question is another technical question about how to do the diaphragm ultrasound. So do you have any tips as to where the M mode line should cut across the diaphragm? For example, do you aim for what appears to be the peak of the dome? And is there a concern that as the diaphragm moves during the respiratory cycle, you are sampling a different section of the structure?
Great. Christie, we'd love to get your thoughts on this, because honestly, this is something that even Caleb and I have been struggling with as we do this research, and we've done close to like 100 between the two of us.
Yeah. So I think probably the most practical tip I have for just ultrasound in general is that ultrasound probes image things best when they're at a 90-degree angle to them. You're going to optimize the proportion of ultrasound waves that are striking the object that you're interested in and bouncing right back to your probe. And so when you are doing diaphragm excursion measurements, what you really want to do is you want to image the portion of the diaphragm that's perpendicular to where your probe is. And so if you take a moment to, when you position your probe in the subcostal position and then aim a little bit medially and a little bit cephalad, take some time to sort of adjust your probe around until the diaphragm looks the brightest white you can get it. Because once you get it to be really optimized in your field of view, it's going to appear bright white because you've got it at a 90-degree angle to it. And so that's what I try to do when I'm imaging. I try to direct the ultrasound waves towards the part of the diaphragm that appears the brightest and is perpendicular to the probe. As it moves, because of the way the diaphragm descends towards your probe, if you're imaging up towards the patient's head, the dome descends pretty homogeneously, so I don't worry as much if you are pointed up towards the dome rather than the side of the diaphragm where it curves down. You won't be imaging a different portion of the diaphragm than what you were imaging before earlier in your clip.
I think a big part of it is also consistency, right? Like making sure that you're consistent day to day to day, and that the inter-user reliability is high as well. Like technically, and we'd love to get your thoughts on this, Dr. Glau, but we tend to use the liver as a great window to image the diaphragm. It's easy. It also doesn't, impair breathing as much and doesn't take a lot of force, right? Because it's a wonderful medium for sound waves to go through. And as you saw from a lot of the papers, they only focus on the right diaphragm. Like that's what Caleb and I were just talking about, is that it is so much more difficult to get excursion values consistently. Is it possible? Yes, but on the left diaphragm, because on that side, you end up using the kidney and the adrenal glands as a window, which is a little bit more challenging, and you have to move the patient around, and then the nurse is mad at you and the kid's no longer synchronous with NAVA, and that's the end of your project. So
unless you got a kid with polycystic kidneys, it's probably going to be easier to do it on the right hand side. Absolutely. The stomach gets in the way, the gastric bubble, the inter-rater reliability in both adults and pediatrics is much higher on the right hand side. And so a lot of papers just don't even bother measuring the left unless you're suspecting some degree of asymmetry, which you would have a heightened suspicion of that for a child that's had a cardiac surgery or some other thoracic procedure where they could have sustained a phrenic nerve injury. But otherwise, I think that you're absolutely right that the right side is your best bet.
We also tend to, as Dr. Glau mentioned on that anatomy lecture, we tend to target away from the central tendon, right? Especially in neonates, where the majority of the work is being done by the posterior components. And Caleb has done probably way more than I have at the bedside. I guess any tips from your end, Caleb?
I think Dr. Glau touched on it. Like, so for us, like we tried to target that posterior third, because especially when a neonate is lying on their back, that's the portion that's going to have the most excursion. And so we just try to kind of take the probe and kind of rotate it so that we're medial, caudal, but also like a little bit dorsal almost. And then, yeah, just trying to kind of find that area, the brightest portion of the diaphragm, and then the area that subjectively looks like it has the most excursion once you get that view.
Yeah.
There's an interesting question about technique, I guess, in the chat box about using a curvilinear probe as opposed to, the phase array probe is what a lot of the images showed. I think that's what's been described a lot in the adult population and pediatric population. I don't see why it couldn't be used. I think we use it for other purposes. And I think the metrics on it really depends on the scalar vector that, or scalars technically that it's giving you, and vectors technically on the M mode.
Yeah, we operationally, we didn't have curvilinear probes in our institution, but I agree, there's not a technical reason why you couldn't use that if that's what you have at your disposal, for sure. It shouldn't be necessary to use a curvilinear probe in the neonatal population, but
That's actually a good point. That's something we haven't tried. The one thing I will say is that some of the newer machines on have that virtual convex feature that might actually throw it off because it's basically moving the lateral crystals off a little bit. But
yeah.
so I would avoid using any sort of virtual function on it. But I think it'd have some good reproducibility. Now that you bring that up, maybe something for Caleb and I to remember, because we could easily measure it with the phase array and the linear probe. We have both, so.
Mhm.
Great. And this next question is again for all of the panelists. Is there any way to stimulate or train the diaphragm to function better and have better excursion?
I feel like that's what we do as pulmonologists on the outpatient side, is we try to have kids spend less and less time on invasive support, and that trains them. I think one of the really interesting pieces that Dr. Glau presented was that concept of pressure support, right? Like that, I think it's not common in a lot of neonatal units if you're using a lot of assist control ventilation, because you do see that then on the diaphragm end. And that's one of the big things that Caleb and I are interested in, is what happens when these kids are mostly on time cycled ventilation, where they're not being able to generate that initial force. What happens to the diaphragm? I mean, interestingly, at this point, anecdotally, our ends are still small, but we do see that the diaphragm looks very different on chronic ventilation.
Yeah,
It
it's
would be
really
so
thinned out.
to
Yeah.
see the difference between AC, SIMV, and vape Nava. That would be really, really cool to see.
Yeah, at least in the adult literature, the allowing patients to spontaneously trigger is more protective than having them do more work. So if you have a choice between having a higher mandatory rate or having higher or lower pressure support, it's probably better to have patients have a lower mandatory set rate and trigger the vent more often, and then use pressure support, optimize your pressure support to give them the minute ventilation that they need, than it would be to try to get their pressure support down, because then you're risking sort of under supporting them and having disorganized muscle fibers and damaged diaphragms, and you're not letting them trigger as much. So the act of actually triggering is really, really protective.
100% agree with that. Just in general, I think triggering, I know there haven't been great studies on it, but I'd imagine just based on what our pediatric and adult colleagues have seen, it is very protective to have that muscle. And, as that earlier portion of the lecture mentioned, that for neonates and anyone really who's supine, you can't engage your accessory muscle. So 90% of the work of breathing is from your diaphragm. And it's already not in an optimal position, right? It's already more flat, so you don't have that piston-like movement that we have. And your ribs are also are preset horizontally, so that bucket handle expansion isn't there either. So I think it becomes really important to follow, and diaphragm ultrasound in my mind provides some of that. Like, interestingly, we're looking at this in the neuromuscular patient population where they're going to have degeneration of muscle like Duchenne's or Becker's, to see if diaphragm ultrasound can predict earlier the need for BiPAP, because ultimately that's what extends the longevity of those patients.
This is so interesting because I feel like there are a lot of takeaways from today's webinar, but that is immediately applicable at the bedside. Like if my patient's on SIMV and I'm deciding between weaning the rate and the pressure support, now I'm going to wean the rate because, you know, I don't want my patient's diaphragm to atrophy. All right, so the next question, again, for all the panelists is how is the diaphragm affected by sedation? Do you recommend avoiding sedation during invasive ventilation when thinking specifically about the diaphragm?
Yeah, I mean, our sedation practices are going to be different in the PICU. What I would say is that ventilator dysynchrony is harmful to diaphragm health. You get worsened diaphragm injury if you're really dysynchronous with the ventilator. And so if you're undersedated, that can cause problems too. But I'd love to hear what the other two panelists have to say, because their sedation management is just so different for your patient population.
Yeah, go ahead, Caleb.
Yeah, so I guess I have not seen any difference like either way. I'm trying to remember off the top of my head. In our kind of subjects that we've enrolled, most of them were actually on minimal sedation. We've had one kid that was neuromuscularly blockaded, but full paralysis. And really, I think for him, it was more kind of a subjective appearance of when we looked at the diaphragmatic excursion. You could almost it almost looked like a kind of a pressure waveform that you would see on a vent, where it was pretty,
yeah. And
yeah,
that's
just
what we
like a
end up
lack of
seeing.
triggering.
So I think that Caleb, like Dr. K brings up a great point there, because one of the things that we have used diaphragm ultrasound for, it's a relatively easy procedure that I think a lot of people can learn, is using diaphragm ultrasound to see if you are tracheally intubated, right? Because you should get bilateral excursion, and it's relatively easy to go midline, especially on babies. The reason I bring that up is many centers are now using neuromuscular blockade, which makes it even easier. But the way you see the diaphragm move on that is very much more almost block-like, instead of having more of that smooth feature. And I think that could be a function of various things, right? We assume short time constants in our patient population. So our I times tend to be short, our rise times tend to be really short. So it is very much and then that exhalation. So you see the diaphragm drop off under neuromuscular blockade, which isn't the normal contraction pattern of the diaphragm if you look at the excursion metrics. So I do think long-term neuromuscular blockade will, of course, much like your other muscles, atrophy the diaphragm out. But one of the things that we are seeing that Dr. Cave mentioned is that the diaphragm almost takes on a different appearance. There is a subjective appearance to it that's different, but it's hard to quantify it, right? It's like the radiologist telling you that there's ground glass opacities, but you don't know how to really quantify it. It's just there.
Excellent. And we have time for one more question. What are some of the challenges with diaphragm ultrasound that you have encountered?
Yeah, as a trainee, I can just start and then I'll defer to the people that have more experience. But I think for me, yeah, it was more just kind of the position of the end mode cursor when you're trying to get excursion. I think that was kind of the biggest learning curve for me. But I think, like Dr. Sharma mentioned, just kind of doing the scan the same way every single time was something that helped me early on.
I do agree with Dr. Glau that it is one of the easier things to learn, right? Like to learn diaphragm ultrasound is significantly easier than learning the 4 different positions, 5 different positions for cardiac views. If you consider the sweeps, it adds a whole new feature. I think it's a lot easier, but I will say that consistency is really important, because what I'm doing could be slightly different than what Caleb is doing, but it might really throw our research off. And that's important because as we expand these to multi-center projects, we need to have some degree of a consistent protocol. And I do think it takes about 10 to 15 scans to get to consistency. because I do think that that could really impact the data that we're deriving from some of this, especially since, for Dr. Cave's project, he's more or less measuring every 24 hours. So you want to make sure the value that you're getting isn't just different based on where you're measuring. One of the early things I learned was that make sure your patients are positioned relatively the same way.
Yeah.
Because we have protocols in our unit to move these kids around as they do in the PICU and CVICU, you're going to get very different values in a sideline patient than you will on a supine patient, and prone, probably even more so.
Yeah, whenever we've done studies, we've buddied up and gone around and just scanned together, watched each other, and picked up tips. So it's always good to have a buddy when you're learning ultrasound.
Yeah, 100% agree with any kind of ultrasound. Do it with a buddy. I think it just makes it less scary too. One of the things we did find is that working with our nurses has been really helpful on this. They more or less know when we're coming to do these, so they'll set them up like for us, which allows the kid to calm down. Because this is a thing where if you have agitation, that value is going to be different, right? It's no different than putting a Nava catheter down a kid and trying to derive information on whether it's working or not for the first hour. You're measuring the same exact muscle here. So if they're in a state where they were comfortable and then you stir them up, or they have a dirty diaper, your excursion is going to be different if they're crying and stuff. So it is state dependent.
Warming your gel can go a long way. And then same for vascular access. The probe doesn't actually have to be touching the patient. You just can't have air in between the probe and the patient. So if you stack up a lot of warm gel and don't press the ultrasound probe up against the patient's skin, sometimes that can be less agitating to children and can make them less jumpy and will give you more accurate values.
Awesome. I love those tips. Thank you all so much. We're out of time, unfortunately. But thank you so much to Dr. Glau and Dr. Sharma and Dr. Cave for this wonderful discussion. And thanks everyone for joining us. Please join us next month for our webinar on October 22nd on the safer protocol for decompensating neonates with Dr. Yogan Singh. Thanks so much, everyone.
Thank you for having me.